All right, maybe we can get started now. Hi, everyone, and welcome to the Lunchbox Talk, which is a collaboration between the University of Washington Center for AIDS Research and Public Health Seattle and King County. Today, we are delighted to have Dr. Julia Hood, who is an epidemiologist with Public Health Seattle and King County and an affiliate assistant professor in the Department of Epidemiology, talking about her work on overdose surveillance in King County. Dr. Hood is an epidemiologist with Public Health Seattle and King County, and she manages the overdose surveillance program and implements risk assessments and program evaluations at Public Health. I asked Julia for a fun fact before we started the talk, and her fun fact is that she is a dog mom of several years and will be a baby mom of 1 year as of this Thursday. So congratulations on getting a live human being through their first year of life. It's not always easy. Thank you, Julia, again for agreeing to present your work to us, and take it away.
Thanks so much, Roxanne, and it is an honor to be here today. Thank you very much. As Roxanne mentioned, I'm an epidemiologist with Public Health Seattle King County, and then I'm also an affiliate assistant professor at the University of Washington in the Department of Epidemiology. I'm hoping to cover quite a bit of material today, but hopefully it won't feel too rushed. I want to first go over a brief overview of national overdose epi trends and how that relates to what we're seeing locally. And then I want to dive into some of the methods and some of the complications related to overdose surveillance. And in particular, I'm going to focus on case definitions of drug overdose, and then how drug overdose surveillance data has been used for programmatic purposes, the various behavioral assessments that are underway, and just a quick mention of the need for more program evaluation. First, let's start with the national. In November 2021, CDC reported that US deaths attributed to drug overdoses topped 100,000 for the first time. The CDC said that there was an estimated 107,000 overdose deaths in 2021, which was a 15% increase over the previous record set in 2020. Through this reporting, I think the media has definitely picked up on the overdose crisis and how quickly it worsened over the pandemic years. And these heat maps, also from CDC, show accrued death rates for drug overdose per 100,000 by county each year. The color scale indicates the magnitude of the estimated county level death rates. And you'll notice here that the rapid escalation of overdose crisis nationwide, especially between 2015 and 2020. The opioid epidemic is oftentimes outlined in 3 distinct waves. The first wave began with the increased prescribing of opioids in the 1990s, with overdose deaths involving prescription opioids increasing since at least 1999. The second wave began in 2010 with a rapid increase in overdose deaths involving heroin. And then the third wave began in 2013 with significant increases in overdose deaths involving synthetic opioids, and in particular fentanyl. Now, I want to make the note that these waves, they're depicted here, makes it seem like it's nice, clear temporal bounds. But in reality, there was a lot of geographic variation on the temporal rise of each of these waves. So with regard to the wave of opioids, in this Science article now depicting outdated data, that you see the rise of prescription opioids and then the subsequent rise of heroin and then fentanyl really started in the Appalachian Northeast before spreading westward. This is slightly more up-to-date data from CDC. The top map shows the percentage of 2019 deaths involving fentanyl. And you can see the east eastern states, especially in the Northeast and Appalachia, a higher percentage in 2019 involved fentanyl than what we saw along the West Coast. But the percentage change between 2019 and 2018 was greatest in our state, as well as California and other states, reflecting the delayed trend in the role of fentanyl in overdose deaths. And the opposite was true for stimulants. So methamphetamine rose in prominence first in Western and Southwestern states. Similar maps from CDC show overall percentage of overdose deaths involving stimulants is greatest along the Western region, but other regions of the country in higher percentage change in the percent of deaths of overdose deaths involving stimulants. So now I want to pivot to how these trends observed nationally have played out at the local level here in King County. Nearly all the information I'm about to present are available on the King County website at kingcounty.gov/overdose/data. Between 2012 and 2020, the number of overdose deaths attributed to a combination of stimulant and overdose use modestly increased year after year. From 2020 to present, this increase in overdose deaths has occurred at a near exponential rate. So between 2021 and 2022, the overdose deaths increased by 40%. And this is of a similar increase that occurred between 2020. Sadly, these concerning trends appear to continue into this current year in 2023. Now, all the previous slides have focused on overdose deaths, which are a fraction of all overdoses that occur in King County. So these increases in overdose is definitely burdening our healthcare systems. So we present data reflecting EMS agencies, and the number of overdoses treated by King County EMS agencies has rapidly increased since. If you compare the 2021 numbers reflected in the right cumulative line graph in orange, compared to 2022 numbers reflected in red in the line graph, there was nearly a 60% increase in the number of overdose events attended by King County EMS agencies between 2021 and 2022. Circling back to what is the cause, what's driving this sudden rapid increase, and it is the rise in fentanyl. So when we look at the overdose death trends stratified by whether or not fentanyl was involved, you see a massive jump in the average number of overdoses involving fentanyl. Whereas when you exclude overdose deaths, or when you exclude overdose deaths involving fentanyl, the number of overdose deaths has remained fairly stable. So we're estimating about 70% of 2022 overdose deaths involved fentanyl, and this is up from less than 10% in prior to 2018. So this is just a very quick shift in the drug supply and the context of the overdose crisis. And there are other important trends to note related to overdose data. So methamphetamine continues to play a major role. And just recently in 2022, we saw an increase in the involved overdose deaths, actually a decline in the number of heroin involved overdose deaths. Important to keep in mind that most overdose deaths are attributed to polydrug use. In 2022, we estimate thirds of overdose deaths were attributed to more than one drug class, and then the most common drug classes are represented on methamphetamine, accounting for 36% of all. The diagram on the right shows the overlay of the types of drug classes that are implicated in the overdose deaths that occurred in 2022.
Julia, sorry to interrupt. Your sound is cutting in and out a little bit. Is there anything that you might be able to do?
Okay, is this better if I talk louder or?
I think so. I don't know. It was sort of inconsistently happening. Maybe just try talking louder and we'll see how it goes.
Okay.
Thank you.
Thanks for letting me know, and stop me again and I can try to find a microphone. So we have far more detail of the breakdown of how the overdose crisis is affecting different subpopulations, which can be viewed at kingcounty.gov/overdose/data. At a high level, the most impacted subpopulations by the recent surge in overdoses have been men, American Indian Alaska Natives, Black and African Americans who are non-Hispanic, persons experiencing homelessness, or persons living in a facility managed or subsidized by a governmental or social service agency. And then recently, the surge in overdoses has been, Seattle's been hit the hardest. So there had been an increase in South King County, but over the course of the peak of the pandemic years. But this surge between 2021 and 2022 has been most acutely felt by Seattle. And then on our website, you can view a map with neighborhood-specific estimates. Now I'm going to pivot to discussing the various methods that go into overdose surveillance. And first, I want to go into the complexity of defining what constitutes drug overdose. And I'm going to spend some time on describing our two key data sources. So when I was presenting the national trends, those are based on vital statistics data, in part because it provides a standardized approach to analyzing and defining drug overdose deaths that facilitates cross-jurisdiction comparisons. So the vital stat data attributes deaths according to the residence of the decedent. It defines overdose with regard to the underlying cause of death ICD-10 code. And in contrast, locally, we tend to report and focus on King County Medical Examiner Office data, which differs from the vital statistics data in several important respects. So it assigns deaths on the basis of where the overdose occurred rather than the residence of the decedent. It looks across literal cause of text fields for indication of acute drug intoxication or poisoning, so not limited to a single underlying cause of death. And the reason why we tend to focus our public-facing dashboard and summaries of data on the King County Medical Examiner's Office data is that it's available in real time, and it gives us insight into overdose locations. And it may better reflect where people were actually living, where injuries occurred compared to the vital stat data. We've done a head-to-head comparison of the two. And one thing that we noticed was the complexity around the residence of persons who were experiencing homelessness at the time of death might be misattributed and since such a large proportion of overdoses occur among people experiencing housing, we found that this could bias the estimates of overdose for King County. The other key reason why we tend to draw upon and focus on medical examiner data is that it is available almost in real time, nearly soon after the death occurs, versus the vital stat data tends to operate at a 9+ month delay. But the reason we tend to just put blinders on what's going on elsewhere and focus on what's happening here locally, we don't have as great a need to do the cross-jurisdiction comparisons. So it suits our purposes to go with the medical examiner data. But we realize that there are people who use our dashboards and that do want the cross-jurisdiction comparisons. So we make that data available on our website. So this Venn diagram summarizes the overlap between the two data sources with regard to the number of overdose deaths that are reported for King County based on MEO data source versus the VitalStat data source. And the button at the bottom of our dashboard shows how people who visit the King County website can toggle between views to either view overdose surveillance summaries based on King County medical examiner data or the Washington State VitalStat. And then we've also discussed the differences and the nuances between these two approaches to defining overdose at a national conference, and we're working on a manuscript that describes these nuances. So defining drug overdose in the context of syndromic surveillance is actually more complicated. So we look to data sources, including the emergency department data, as well as EMS data, to conduct syndromic surveillance. The idea is that these data sources provide population-based coverage that would allow for us to surveil all or a larger proportion of all overdoses that occur, not just those that are fatal. And because it is more complete, might enhance our ability to detect overdose clusters and emerging drug threats and other events of public health importance. The how is where the complexity comes in. So we have developed queries of either EMS or emergency department electronic medical records for indication of overdose. I've already mentioned the advantage listed here, but there are a number of challenges, including inconsistencies in how overdose is documented, spectrum of clinical presentations, reliance on free text searches, a lack of gold standard indication of overdose status, and considerable variation in the level of detail documented. So the two key data sources are the EMS data, which is managed by the King County EMS Division, and emergency department data, which is managed by the Washington Department of Health Rhino program. Both are near real time and nearly entirely complete. The data elements vary between the two, and they're listed here. But to give you an example of what we're querying and what we're looking for in the medical records is listed here, and this is a snapshot from our website. But we define a probable or possible overdose event attended by a King County EMS agency as an incident that met at least 4 of these 8 criteria. 8 criteria include primary or secondary impression indicative of overdose, opioid is mentioned in the chief complaint or narrative, overdose is mentioned chief complaint or narrative, low respiratory rate, low Glasgow Coma scale, or notation of decreased level of consciousness, naloxone administration, pinpoint pupils mentioned, documented, and then a drug term included in key fields of the EMS record. So at a high level, we're triangulating information across many fields. Many of these criterion rely upon free text searches, which are somewhat inherently messy, and you do your best to account for potential misspellings and abbreviations. And so it's an imperfect process. Important as a means to improve the way that the syndromic surveillance overdose queries are implemented, we've now conducted an evaluation on both data sources a few different times to both initially develop and then refine are overdose case definitions that are applied to these data systems. Basically, the evaluation approach takes these 5 steps. So we first generate a sample of records that are both purposely and randomly selected from a data system. We manually review relevant fields and categorize each record according to its likelihood of being an overdose event. Then we implement an automated syndromic overdose case definition on the same sample. And then we assess how well the automated categorization aligns with the human overdose categorization, which for the purposes of our evaluation is considered treated as the gold standard. And then we iteratively adapt the automated definition until measures of sensitivity and positive predictive value are maximized. And we've compared the performance of each syndrome definition, and none of them are perfect, as you can see here. The definition that we've ultimately landed on, that where we put most of our focus in terms of monitoring the incidence of overdose, is highlighted here. But even with this definition, it makes us aware that using this definition, we're missing potentially 16% of all overdoses, and approximately 20% of the overdoses that are flagged by the query might not actually be overdose. We are aware that our best performing syndrome definition of overdose still has imperfections. Even with those imperfections, it is the definition that we've chosen to reflect on our public-facing dashboard, available at kingcounty.gov/overdose/data. There's been a big push at the federal level for local and state agencies to pursue data to action. This is very much in parallel to, I think, the data to care programs and initiatives undertaken in the HIV realm, except in the overdose realm, it's much more focused on the detection of and response to emerging drug threats, and then potentially using overdose data to connect people who survive overdose to linkage and support services. So I'm going to discuss how we have applied the data to action initiative at the local level. So first, we define overdose events of public health importance as when the observed incidence of overdose in a given geography or neighborhood exceeds what is expected. We look for linked overdoses, or people who are overdoses simultaneously or in close proximity. And other events in which the specific drug threat was previously thought to be non-existent, uncommon, or recently increasing in a given subcommunity of King County. So everyone, for example, everyone's on high concern about the potential of xylazine rising in prominence here in King County, which, knock on wood, we haven't yet seen. But that would be if we did start to see an increase in xylazine involved overdoses, that would meet that third bullet criteria. Given the high volume of overdose events that occur, finding these events of public health importance, it's kind of like finding the needle in the haystack. So it might seem very straightforward, but one thing that we do is we very closely monitor neighborhood-specific trends and compare the observed to expected. So on the right, I'm highlighting downtown Seattle, or really this slide. And on a monthly basis, we've just seen a rapid increase in the number of overdose EMS encounters for suspected overdose in downtown Seattle over the past 12 months. And then the bar charts below summarize the downtown overdose data by week. And the gray line indicates the weekly average over the course of the 12 months. And the bar, we look to see if in the most current week, how far it exceed the weekly average as a sign that something could be going on specific to that area that deserves attention. We've just recently started moving to using SAT-SCAN, where we do more specific it's a more robust package for automated cluster detection, and it's used to detect if one dimensional point is purely random. So we associate a fixed event not only with a specific place, but also with a specific time. We can objectively measure the high or low clusters through space and time that significantly deviate from the norm, and it allows for more precise targeting and analysis of spatial and temporal trends. And we hope that SAT-SCAN will aid in the timely identification of emerging drug threats, because they'll have increased power for weekly scanning, increased resolution, and a shift away from the neighborhood to the point level event monitoring, and hopefully increased accuracy, since it won't be limited by geographic or temporal boundaries. So a lot of work goes into developing the methods and implementing the methods to detect potentially a concerning event. And then we're often faced with the, well, what do we do? What is the response? So when we detect clusters or events of public health concern, first we read them, try to get a sense of what is going on, and we consider questions like, is more investigation? To what extent is this problem already on people's radars? Like, is this a new and unknown or evolving issue, or is this a well-known issue that sadly kind of reflects the status quo or the new status quo? And then we also consider, can health and social service providers, is there an action for them to take to respond to the threat? And is there a role for public health to improve the accuracy or sensitivity of messaging that's communicated by partners? So we weigh through these types of questions, and then we consider what is an appropriate response from the health department. We did recently, by recently now, it's probably been a few years, set up a listserv where people can sign up to receive drug alert threats or emails. If you go to kingcounty.gov/overdose, you should be able to find a link there where we can just quickly notify, there was a double overdose, or we're seeing multicolor pills, or whatever example threat. That's a very targeted approach to messaging. We can disseminate education materials and harm reduction supplies in a more targeted fashion, be it at specific locations like metro, bus stops or light rail stations, or to specific types of social service providers. We can do more targeted communication, either through specific media channels or via key partners. We can convene key partners to see if we can facilitate some kind of coordinated response. And then sometimes we elevate it if we think that the threat warrants general population communication efforts. We'll issue a blog or social media post to try to broadly disseminate information or alert. So that's on the overdose cluster detection and response. But another example of how we try to implement the overdose to action initiative at the local level is using surveillance data to try to offer support services to people who survive overdose. We call this our post-overdose follow-up program. We're actually now into our third phase of this initiative, but essentially we identify suspected overdoses that met the criteria that we discussed earlier, and then we call or text the patient 2 to 9 days after their encounter for suspected overdose. and introduce ourselves, say that we're checking in after their health emergency, and then offer to connect to services. We've undergone 3 different phases, in part because have been trying to refine our methods. It has been maybe a little bit disappointing that the number of people connected to services through this mode of outreach has been lower than we had hoped. So at each phase, we've tried to scale back the level of staff resources required in providing the intervention. Now pivoting away from routine surveillance data to behavioral assessment, which is a little bit outside my realm. I'm going to speak to work that Dr. Sarah Glick leads for Public Health Seattle King County. There are 2 serial cross-sectional surveys that her team leads. One is the NHBS/pitch survey, and it's conducted among persons who inject drugs approximately every 3 years. It's a sample of PWID in the community. It's an interviewer-administered survey. They also do rapid HIV/HCV testing. It's conducted by public health interviewers. It's 45 to 90 minutes long, and it is incentivized. Sarah's team also oversees the Syringe Services Program survey, which is conducted every 2 years. And it's an attempted census of SSP clients. It is also an interviewer administered, but there's no HIV/HCV testing. There's no monetary incentive. It's conducted by SSP and other staff, and it's more concise. It's approximately 10 minutes. These surveys, although they're based out of the HIV program, many of the components of the surveys have direct implications for the overdose prevention programs highlighted here. So we are grateful to the work that the SSP and pitch teams do because they yield such valuable information. To supplement the information collected through the serial cross-sectional surveys, there's also a good bit of qualitative work done with people who use drugs. So my team has conducted rapid fentanyl qualitative assessments in 2017 and 2021. We've recruited people who use drugs from the Needle Exchange Program, Youth Care's Orion Center, as well as Beat Pathways. And what we found was, compared to 2017, more participants in 2021 indicated that fentanyl was readily available and widely used in their social networks. And many articulated the advantage of fentanyl over heroin, including the ease of smoking versus injecting, preferred sense of euphoria, cost, accessibility, and perceived reduced harms. So an example question that we asked in these qualitative assessments was, why are more people using fentanyl now? And someone said, simply, it's cheaper. Someone says it just came out of nowhere and it's very sad, but a lot of people who typically wouldn't even use drugs or anything are trying it because they're hearing about them so much, and then they get hooked. And now I'll let you read the other, well, actually the sentiment that it's sort of taking over heroin, taking over the place of heroin. Heroin seems to be too much of a process, and it's a lot easier to smoke pills. A lot of people that don't sell black anymore, referring to heroin. They just sell blues, referring to fentanyl. And I don't know why, it's like the thing now. And then ADAI has also done a lot of great qualitative work. They have a report on their qualitative assessment involving people who use methamphetamine, where they highlight why participants in their qualitative assessment, both their perceived advantages and disadvantages of using methamphetamine, and what types of services would be desired in this group. And I encourage you to go to the ADA website and review the resources that they have online describing results from this important assessment. And then I think they just recently wrapped up a similar assessment involving people who use fentanyl. And so we very much looking forward to results from their recent assessment on fentanyl. And then I'm the PI on a CDC-funded study that differs from the behavioral assessments previously in that it's focusing specifically on people who recently initiated the use of a high-risk drug class, as heroin, methamphetamine, cocaine, and so forth. So the goal of this assessment is to characterize the drug consumption patterns leading up to and immediately following use of a high-risk drug class, initiation of a use of a high-risk drug class. So I look forward to reporting back to you all once we have results to share from this study. And then finally, I want to just briefly mention program evaluations. There's a lot of work being done in the overdose prevention space and a lot of work that could be done to evaluate these programs. So we're in throes of a public health crisis, and we're needing to act quickly and respond to the crisis. But I think there's a lot of value in evaluating what we are currently doing and the innovative ideas for tackling the overdose crisis. I have been involved in some program evaluations, but I think that we really have just scratched the surface. So this is an area that I'm hoping myself and others will have more time and bandwidth to focus efforts on. So now I'm going to wrap up, and I should have plenty of time for questions and discussion. But before moving into the discussion section, there's so many people involved in this work, so many that I couldn't list people by name, just their home programs. But I'm so grateful, with this work within the health department spans essentially all divisions of the health department, and especially the MEO, EMS, HIV STD program, and the chronic disease and injury prevention program. So grateful to all my colleagues within the health department. And then, this body of work is definitely reflective of the public health academic partnerships. We work very closely with colleagues at the University of Washington, specifically at ADAI, CFAR, the School of Public Health. And then we use REDCap and their support teams a lot. And so very grateful that we do have this close partnership with the UW. And with that, I'm going to stop and would love to have a conversation about anything I presented or anything you want to add, or that's all I have all prepared for you today.
Thanks, Julia. That was great. I did see one question in the chat. I invite anyone who has questions to either come off mute and ask the question yourself, or you can put it in the chat. So there was one question about deaths in jails from Mandy, and that was, do the overdose data include deaths in jails, and can those be separated out?
Yes. So both the fatal overdose data and then the overdoses treated by EMS agencies contain location data, and we are trying to reach consensus on what level of location data to release publicly. So it's there's complexity and nuance in, right now I'm taking a step back from jail specifically. That's just one of potentially many key venues to be closely monitoring the incidence of overdose. And I feel like that is going to be a big area of focus, is calling it place-based overdose prevention or overdose surveillance. So more to come on that. But long story short, the answer is yes.
But not publicly available yet, Julia.
Not publicly available yet.
Thank you.
Thank you, Julia. I was wondering if you could tell us more about the incidents of public health concern or the clusters of overdose incidents. How many of those do we see in a year?
Well, I can more easily tell you every week because we process the data on a weekly basis, at least from the EMS. The MEO data is updated daily and updated to our website through automated procedures. The EMS data is processed weekly, and at that time, we run it through StatScan and compare the most recent week's counts to the prior week for a given geography. And through that process, we might flag, let's say, 5 to 7 potential clusters or aberrations from the norm. And then we'll review line by line all the records connected to those potential 7 clusters or deviations from the norm. And then of the 7 reviewed, there might be 0 to 2 that were like, this is concerning. And then we'll elevate it on. And then we start the dialogue of like, well, is there an action to take? That kind of the bullets that I went through on weighing the question of what do we do with this information. So we're detecting more of them, which is posing, now the easy part is the detection and the harder part is the response. So I think that's what we're grappling with currently.
And how do you monitor those going forward to see if they're accumulating more overdoses? Do you know what I mean? Do you monitor them prospectively, I guess is what I'm asking?
Oh yeah, so all of the monitoring is done prospectively. So on a week by week basis, we're moving forward the previous 7 days as we go along. Retrospectively, now our methods to detect events of public health importance, and especially the transition to using StatScan has changed. So we're definitely detecting more events of public health concern. And I think it's a mix of both. Our methods are improving, so we're detecting more, but then also the number of overdose events of concern are increasing along with the underlying total number of overdose is increasing. And we haven't done more of a retrospect comparison of how this initiative has changed over time in terms of the monitoring or surveillance process.
Thank you. That leads in very well to Eleanor's question in the chat, which was, can you say a little more about StatScan? What data does the software use to track overdose events and trends?
So we have run StatScan on both the medical examiner data as well as the EMS data. But to just in terms of scale, there were in 2022, 1,000 overdoses under the King County Medical Examiner jurisdiction versus nearly 6,000 overdoses treated by King County EMS agencies. Since King County EMS has a greater number of overdose records in their system, we've been putting more emphasis recently on using StatScan implemented on the EMS data. So the question is, what data does the software use? That's the EMS data, primarily, although it could be run on the ME data.
And correct me if I'm wrong, but that's really looking at time-space clusters, StatScan.
Yeah.
Okay. Eleanor, feel free to come off mute if you have any follow-up questions about that. And Susan asks, is younger age a factor of defining what is a cluster of concern?
We do not currently explicitly set our cluster detection methods in terms of age. That said, during the manual review process, we definitely note if the cluster, what demographics appear to be affected by the cluster or involved in the cluster rather.
Thank you. I have another question for you. Your project, which you're going to be doing with people who've recently initiated drug use, what's the plan on recruitment for that group? How are you going to find people?
Yeah, good question. So we're using mixed methods. Currently, we're at the very beginning stages of data collection. We're doing key informant interviews with people who would meet our criteria and getting feedback on our recruitment methods. That said, and maybe I should have mentioned this as part of my introduction, but my career started in HIV surveillance. So I'm very familiar with methods used in the HIV realm to recruit people at risk for acquiring HIV. And in this study that I'm leading, we're going to apply many of the same recruitment methods that are used in the context of HIV. So specifically, we're going to be doing an internet survey. So we'll be placing ads on several key social media sites. We're currently working with a graphic designer on designs for recruitment ads to place on social media sites. So I'm hoping that a large proportion of the people we recruit in the study will be recruited through online sources. Then we'll also do venue-based recruitment and thinking of key venues, like whether that is bars or coffee shops and neighborhoods where there are a lot of young people, or if that's social service sites, like thinking of the sexual health clinic or other key public health clinics and so forth. And then finally, we're going to do an adapted version of respondent-driven sampling. So web RDS. So we'll be using a mode of RDS adapted for online recruitment. But I think that is the question, is whether any of those modes of recruitment will be successful. Although not an explicit one of my 3 aims, a sub-aim is to measure how effective these alternative recruitment methods are in recruiting our target population, we are anticipating our challenging group to recruit. For context, I was motivated to pursue this grant in part because most of our data sources reflect people with long use histories, like chronic, many years, decades long use histories. And that I felt like a hole in our knowledge base of people who are at risk for overdose or people who had just recently started using, and people who vary in terms of chronic use to people who infrequently use or sporadically use, who might still be at risk for overdose and arguably might be at higher risk for unintentional fentanyl exposure.
Thank you. Are there other questions for Dr. Hood? Maybe not, in which case I think we can wrap up. And thank you again, Julia, for presenting this work. I see you have your email here on your slide. So is it okay for people to follow up with you?
Absolutely. Please feel free to connect with me offline via email. I'd love to hear from you.
Okay. Thank you again. Thanks everyone for coming.
Yeah. Thank you much. Thanks for organizing. Take care.
Bye-bye.